ready?
As so.
Are we ready, they're ready to go as of right now? Asville,
Yeah. Your opening statement.
ready, set, go.
Imagine a 7-year-old named Sophia who lives in a rural Arizona town. Her school has no full-time dental provider and her family struggles to reach the nearest dentist. Without preventive care, small cavities can quickly become painful, costly emergencies. This isn't just Sophia's story, it's the story of thousands of children across underserved communities in Arizona. Now, imagine if Sophia had access to the OPA program. Through school-based programs or mobile clinics, a trained OPA could provide fluoride varnish and hygiene instruction right at her school. These simple interventions stop small problems from becoming big ones, all while teaching lifelong habits. Good evening, judges and colleagues. My name is Anastelle Montalbano, and today I will be presenting the case in favor of the Oral Preventive Assistant Program. The question before us is, does the Oral Preventive Assistant Program provide sufficient support for oral health prevention? We argue yes. First, let us define our terms. Oral Preventive Assistants, or OPAs, are mid-level dental providers certified through the Dental Assisting National Board. They provide preventive services including fluoride varnish, supragingival cleanings, and oral health education, all under the supervision of a licensed dentist. Sufficient support means making a meaningful impact in prevention, particularly where access to care is limited. And oral health prevention refers to interventions that stop disease before it starts. Arizona faces a critical workforce shortage. The Health Resources and Services Administration identified over 250 dental health professional shortage areas, meaning hundreds of communities struggle to access even basic preventive care. This gap is similarly presented nationwide. OPAs are designed to close this gap. The essential foundation of care is prevention. By expanding fluoride application, education, and routine hygiene in underserved areas, OPAs provide meaningful, lasting support. According to a 2025 systemic review published in the American Journal of Preventive Medicine, school-based fluoride varnish programs reduce caries initiation by 32% in permanent teeth and 25% in primary teeth. With an estimated 68% student participation rate, these programs are far more effective than traditional clinical settings, where less than 18% of children from low-income families receive fluoride varnish annually. By expanding access to these proven interventions, OPAs can significantly reduce cavities, slow disease progression, and improve long-term oral health for underserved communities. They don't just provide support, they provide the right support where it matters most. That is why we affirm that the OPA program offers essential and effective prevention for Arizona's oral health needs. Thank you.
Thank you.
And now we have 3 minutes for the MWU or opening statement.
Esteemed judges, honorable opponents, and members of the audience, my name is Karina Lamb, and this is Tressa Barney, representing Big Western. We are here today to address a critical two-part question. Does the Oral Preventive Assistant Program provide sufficient support for oral health prevention? Our team's position is an unequivocal and empathetic no. While we recognize the OPA as a useful clinical addition, it is at best a limited component within a vastly undersupported public health framework. Sufficiency cannot be measured by minor staffing increases, it must be measured by population level impact. And on that metric, relying on OPA is a failure to grasp the scale and systemic deficiencies plaguing oral health care access. The program is a drop of water, where the public needs a flood of policy and systemic change. Our first point is simple. The OPA program is inherently reactive. Its primary function is enhancing efficiency within the walls of an existing clinic. It serves the patient who has already achieved optimal oral health and managed to secure an appointment. But prevention must be proactive and community-based. Sufficiency demands far-reaching strategies like mandated school-based sealant programs, comprehensive public water fluoridation, and aggressive mobile outreach in underserved communities. The OPA program, by its clinical design, lacks the mandate, the training, and the systemic leverage to operate effectively outside of the dental office. It cannot bridge these critical community gaps, and therefore, it is fundamentally insufficient in its reach. To provide sufficient support, preventive rules must be equipped with the highest possible levels of clinical autonomy. The OPA's regulatory scope and training duration are demonstrably less than those of a registered dental hygienist. This critical difference prevents OPAs from operating independently in high-need, unsupervised settings where prevention is needed most, places like dental deserts and remote schools. We are actively limiting the reach of preventative care by restricting the OPA scope. Consider this. RDHs have performed over 2,000 clinical live patient hours compared to the vaguely outlined requirement of 120 combined hours for OPAs. Finally, the crisis is not merely a staffing problem. It's a problem of systemic inequity. Placing an OPA in a clinic does nothing to solve the root causes of poor oral health, the lack of comprehensive dental insurance, and the massive financial hurdles faced by low-income families. In 2023, 13% of the population reported cost barriers to dental care compared to only 4 to 5% for other healthcare services. Sufficiency demands policy solutions, mandated public dental coverage, and direct financial incentives for professionals to serve in shortage areas. The OPA program simply bypasses this root policy failure. The current bill is severely deficient and lacks the regulations that protect our local communities. In dentistry, you outline and detail every part of the treatment plan with your patient and promise good care and well. With this bill, the plan is ill-defined and not patient-focused. We're doing a disservice to our community for our not good setting and not setting this non-negotiable standard.
Time's up.
Okay, there will now be a 3-minute crossfire. Please have respect for one another, let each other talk. Don't take the entire 3 minutes yourself. And this is the crossfire, open debate. Whoever gets the mic first, set, go.
Why in the bill for Arizona for OPAs does it not include anything about rural communities? That was removed.
So there is an access issue that is being addressed. The oral preventative assistants are actually required to work in underserved areas for the first 5 years of their licensure.
Where does that say that in the bill then?
It specifically states that they are limited to practicing in federally designated health provider shortage areas or counties with less than 100,000 individuals for the first 5 years of licensure. It states that in the OPA pilot project.
Are you aware that that was removed in the final bill that was passed?
I was not aware that it was removed. However, OPAs are, they can be recruited to these rural areas because there are actually a lot of people that work in rural areas currently that want to extend their clinical skills that are assistants.
How many hours of training do OPAs need?
They need 120 hours of training, but that's in addition to having a certified dental assistant license, which requires them to take the board. And if they don't have that license, or if they don't have training from a accredited school, then they have to have at least a high school diploma or a GED and have at least 2 years of experience, and that needs to be validated by a licensed dentist. So not only is it 120 hours of clinical work for that specific training,
Do you
but
think
it's
that's
in
enough?
addition to the
Do you
training
think
that they're
120
having.
hours is enough?
Because
To
normally,
take sharp instruments and cabotrons into a patient's mouth.
registered dental hygienists spend thousands and thousands of hours to be clinically trained. Not on top of that, they have to find their own patients, and that is hard in itself. We're not even addressing the real main issue, which is cost for, for dentals. Like dental insurance it's so outdated. The maximum usually for dental insurance is what, $2,000. How much is an implant usually? Over $3,000. Patients that you guys are specifically saying that OPAs benefit for, you guys are mostly talking about children. If you look at insurances that cover for children, it's mostly because they're at the age under 18 for these cleanings. We're not even addressing the rest of the population. Older people, right? And most of the time, people in that age, in that population, They have periodontal issues that's.
Hey, whoa.
Oh, sorry, I didn't hear that
You
correctly.
get your rebuttal coming up next.
Okay, thank you.
And that will be next, is the Midwestern rebuttal. You have 3 minutes. When does the time start? Go.
They say that 120 hours is sufficient enough for an OPA to go in with hand instruments and ultrasonic scalers. These instruments can cause tissue damage, bone damage, and the vitality of the tooth can be damaged as well with these instruments. 120 hours. In the state of Arizona, you need 1,000 hours and 250 hours in order to become a hairstylist, and 700 hours and licensure to become a nail tech. So what Arizona is saying is that OPAs need 120 hours with no guidelines. Just they have to be a CODA-approved school. That's it. That's all you have to have. There's no guidelines on how many clinical hours or how many didactic hours. So what they're saying is that nail techs require more time, more licensure than somebody who's going to clean teeth. So
Yeah, it's all you.
the funny thing is that in all of these bills, they're talking about how access to care. But oddly enough, Medicaid doesn't even cover oral preventative care for anybody over the age of 21. So the ones who are getting the care are the children because they're covered. Anybody over 21 or not, they get $1,000 in emergency care, which means that they have to be symptomatic. They have to have pain in order to receive any type of care. Oh, and $1,000, that's it, that's all you get. So the real problem is not access to care. The real problem is the fact that legislation doesn't want to invest in education. Because there's a 3-year wait list for dental hygiene school. 3-year wait list. So OPAs aren't going to fix it because they're asking OPAs to be trained by the same ones that are trying to train dental hygienists. So how does that make any sense? That you're going to sit there and say this burden education system that can barely push out enough dental hygienists, and now you're going to ask them to train OPAs and train them 120 hours to do scaling and root planing? That's absolutely insane to me. There needs to be more control, there needs to be licensure, there needs to be accountability, and the safety of the people of Arizona need to come first. So at the end of the day, this is not the solution to the problem. The solution would be actually investing in Arizona education.
Time's up. Now, the last segment is a rebuttal from the ASDO team.
We don't want to hear it.
3 minutes.
We don't want to hear it.
Please, everyone quiet. We've got a rebuttal from the ASDO team. 3 minutes. Go.
Good evening. My name is Claire Murphy, and I'll be delivering the rebuttal for the ASDO team. We just heard concerns about the Oral Preventative Assistant Program. Let's look carefully at the claims and the real evidence behind them. So one thing that the opposing team did not mention or claimed was that oral preventative assistants were learning how to do scaling and root planing, which is not true. They're only allowed to scale supergingivally, which by itself, that harbors plaque, that harbors carcinogenic and inflammatory bacteria. Consistent removal does reduce the risk of gingivitis and early formation of dental caries. Maintaining good oral bacteria supports gingival health and prevents progression to potentially irreversible subgingival infections. And teaching patients proper plaque control helps them establish lifelong oral hygiene habits, reinforcing preventative care and promoting long-term outcomes. Additionally, reducing bad oral bacteria can help prevent exacerbation of oral conditions such as cardiovascular disease, diabetes, and respiratory diseases such as asthma. Dental professionals should work to prevent periodontal disease and dental caries, rather than just treating the aftermath. There's also data that supports that an OPA program would work. It's based on the model of a periodontal FDA. Since 1977, the Indian Health Service has trained and employed periodontal FDAs, which are similar to the OPA FDAs. The IHS internal evaluations indicate that clinics with periodontal FDAs compared to clinics of similar staffing, stability, and size experience a 6.5% increase in preventative services provided to patients. And a 2017 external evaluation conducted by the Johns Hopkins University Bloomberg School of Public Health revealed that clinics with at least one periodontal expanded functions dental assistant provide 12.1% more total services compared to similar clinics of the same size and staffing stability that do not have the EFDA. Currently, there are over 1,200 periodontal FDAs who have been trained and are serving patients in 36 states. For these reasons, we affirm that the Oral Preventative Assistant Program does provide sufficient support for oral health prevention and access to care. Thank you.
All right, we're gonna give you guys about 2 minutes as a recession, just kind of gather your thoughts and plan for the next crossfire, and then we'll have a 3-minute crossfire followed by the closing remarks from both people. So we have 2 minutes right now.
Turn on the AC. Oh, their friends are helping them. Oh my god, what a bunch of elves. They need help.
يا عم الحاج بعد يا عم. Bisa dikirim sini ya? Oh hell no! You thought I died to send it to you? I'm kidding. I'll send it. You're good. I got you. I'll probably airdrop it. It's gonna be faster that way.
Big head is coming to you. Why are you recording it? Why are you recording it?
To take clips from it and post them.
Why don't you just take it?
Baby, I'm gonna cut it like segments and then trust me.